I had mentioned rural in addition to urban, and I have to declare actually an ADA embargo because two of the presentations which we submitted are both accepted for presentation. So I'm slightly compromised in present or not presenting the data which I had actually wanted to present. So I'm going to refrain from some of the things which we have mentioned in these abstracts. I'm going to start by paying my respects to my guru, David Barker, who after I started my career in research came one day to meet me in 1991 and completely changed the life of me and my unit, whereby after investigating the characteristics of diabetes in India, we just got into the developmental origins world. As you know, he faced a lot of criticism, but maintained his posture, and actually today we are benefiting from what he has done. All of us read the textbooks, and this is the current dogma of diabetes. We have a genetic susceptibility, and like say yesterday, Dwapa and Stock, we learned there might be now 76 SNPs which are associated with type 2 diabetes, but all of them don't explain more than 7.5% of the variability. So all the big hype about genetic susceptibility has not really paid off. We concentrate on the precipitating factors, and most of them are obesogenic, whether they come from the intake side, diet, or the output side, the physical inactivity, or stress with its unknown effects on multiple endocrine metabolic axes. It would be really interesting to see if there is an additional susceptibility to diabetes, because when we say genetic susceptibility, we basically admit that we can't do anything about it. It's a non-modifiable. And my research under David Barker's guidance has concentrated on trying to find out a modifiable non-genetic susceptibility to type 2 diabetes. And one of the modifiable factor is of course nutrition. And how confused we are about nutrition is seen from the reports of WHO committees. The 1965 committee, which was headed by Harry Keene, said that evidence that malnutrition protects adult populations from diabetes seems unassailable. So basically saying that based on the results from Second World War, that people when they were starved, diabetes prevalence had dropped. In 1980 and 85, they made a statement that malnutrition is probably a major determinant of diabetes, saying that malnutrition-related diabetes, which was described from India and other tropical countries, was actually a major illness. I started my career with this. In 1996, I wrote a position statement on MRDM for the WHO IDF committee, for basically George Alberti and Paul Zimet. And the recommendation was to continue the entity but put in more research for reasons best known to the committee. They just withdrew this. And you can see how confusion actually has mounted about the role of overnutrition, undernutrition in diabetes. These are the maps from the famous World Mapper site. And as we know, in these maps, which are also called cartograph, the size of the committee, the size of the country, depends on the burden of that condition in that country. So if you look at world map of diabetes, India and of course China are the two fattest countries. Now diabetes in textbooks is equated as an overnutrition disease. If you look the cartogram for undernutrition, especially under 5, including low birth weight, India is undoubtedly the fattest country. So it's quite paradoxical that India carries the largest burden of undernutrition in early age, as well as diabetes, which we equate with overnutrition. And this itself should have given us a clue. The first clue came when I was a registrar working in Sassoon Hospital. And this paper in New England Journal described the weight and obesity risk in people who were born during the Dutch winter hunger. If you were in mother's womb during third trimester of the pregnancy and faced the famine, you were less likely to be obese, the red line. If you were in the womb in the first 2 trimesters, you were more likely to be obese at 19 years as army conscripts. And they had talked about programming in various phases, including programming of the fat cell number or the hypothalamus, which led to this, indicating that undernutrition in early life predisposed you to either less or more obesity depending on the window of exposure. Thus, life course nutrition history is more important than what we look for in the clinic in a patient. And that's how life course theory has become quite important in relation to diabetes and obesity. This is a life course map of my unit's activity in last 25 years. Trained as an adult diabetologist, we started in adults and did many studies, generated ideas about characterization of diabetes, and then have gone backwards, first in children, then in pregnancy, and then finally in a preconceptional stage. And now we have started world's first preconceptional intervention to improve nutrition of the young girls to reduce the risk of non-communicable disease later in the life. The study which drove this is David Barker's famous study in Hertfordshire, where he showed that birth weight was inversely related to risk of high glucose and to risk of what we that time called syndrome X. And he put out the idea that type 2 diabetes is the outcome of the fetus and early infant having to be nutritionally thrifty because of undernutrition. And this is the famous thrifty phenotype hypothesis. My contribution to this hypothesis is I suggested to David Barker the name thrifty phenotype when he came to Pune to meet me, because we were all fed on the thrifty genotype hypothesis. So I said, you are challenging it with a phenotype. The first study we set up in Pune is called Pune Children's Study. This was full-term singleton babies born in KEM hospital. We went to the hospital record and there were 1,856 born between 87 and 89. We wrote to all of them. For each 5 letters we wrote, we got 1 response. And then we offered to study the children at 4 years of age. So finally, we ended up studying 404. They were studied in 1991 to 93 with a glucose tolerance test and some other measurements. They were followed up in 1996 to 97 when they were 8-year-old with addition of some extra children to increase the power of the study. Then we followed them through their puberty, and in 2009 to 11, we studied a total of 383 of them in an extensive manner to see how their birth weight was related to the outcomes at 21 years of age. The first paper out of this described that low birth weight or lower the birth weight, higher was the glucose and insulin concentrations in these children as early as 4 years of age. This was the demonstration at earliest time of a possible effect of low birth weight on increased risk of insulin resistance and therefore future diabetes. This is published 1995. When we followed up these children at 8 years, we noted one more interesting finding, which in retrospect was there at 4 years also, that children who were born with the lowest birth weight, the lowest tertile, but who had grown heaviest at 8 years, were the most insulin resistant. So if you're born small, but you grow big, then the risk of all the non-communicable diseases increases. Here I have shown it for insulin resistance, but that's true for central obesity, cholesterol, blood pressure, triglycerides. All the known cardiovascular risk factors are highest in children who are born low birth weight but become heavy later on. This is 1999 diabetes publication. Then, as I said, recently we called them at 21 years and we did a plethora of tests like we now are doing in all other cohorts also. So in addition to the history, family history, various other special tests, we measure body composition, glucose tolerance tests, cardiovascular measurements, some other endocrine things. We are also collecting microbiota and buccal smears, etc. Dermatoglyphics, which I am not going to talk about today, but very interesting findings of dermatoglyphics and risk of disease in later life. And sonography and other measurements. At 21 years, there were 191 boys and 166 girls, and their average birth weight was about 2.7, 2.8 grams. At 21 years, the average weight of boys 65, girls 52, body mass index 22 and 21. Total body fat percent, as we have noticed before, quite high for these given BMI compared to the Westerners. International criteria, overweight about 18%, obese very few, hypertensive about 5 to 7%, high triglycerides about 7 to 8%, low HDL very common, and on the glucose side, about 10 to 12% had high fasting glucose above 100, ADA criteria, impaired glucose tolerance 5 to 7%, few children were already known diabetic and we diagnosed more. In general, 18 to 20% had either prediabetes or diabetes at a young age of 21 years. And what were the characteristics of these who had high glucose compared to those who had normal glucose? They were heavier, had higher BMI, higher waist circumference, higher body fat, higher blood pressure, higher cholesterol, higher triglycerides. Classic sort of syndrome of cardiometabolic. And they had higher insulin, higher HOMA. The HOMA beta at this time appears higher, but if you put it as disposition index, it's clear that their beta cells are working much less for the given insulin resistance compared to those who have normal glucose. So it is a beta cell defect, though they are insulin resistant. So what was the relationship of birth weight with and current BMI with the glucose tolerance? And this is used in literature now, Lucas's modeling. There is an early, late and a combined model. Early model looks at the effect of birth weight. And there was an inverse association of birth weight with 120-minute glucose and insulin sensitivity direct. In other words, those who were born lower birth weight had higher glucose and were more insulin resistant. 21-year parameters were obviously related to glucose and insulin resistance, but when you put them together, those who were born lower birth weight and had grown subsequently had higher glucose and higher insulin resistance, replicating what we had seen at 4 years and 8 years, continuing into 21 years. First time in the world where a serial thing has been demonstrated. So it's a persistent, stable prediction. And there was no interaction between these two. In other words, now for the first time we are saying that those who are low birth weight when they progressively gain weight in later life, are at a higher risk of diabetes. We discussed height day before yesterday, and this is what actually made me say that. Height is a surrogate for early life nutrition. Intrauterine, whenever their fetus is challenged or there is an adversity, the blood flow adjustments divert the blood flow to the brain, and that's the brain sparing effect, and necessarily the lower half of the body suffers. That's called caudal diminution. Short legs, therefore, are an indication of early life adversity. So in Pune Children's Study, we have measured height, and interestingly, we are quite short compared to the CDC scores. The boys were about 6 standard deviations shorter, girls almost 0.9 standard deviation shorter. So we are stunted. And when we look at relationship of total height, height was inversely related to blood pressure, glucose, insulin resistance, and triglycerides. It was significant for 2-hour glucose. In other words, shorter people had higher glucose. When we divided that into leg length and sitting height, it was the leg length which was predicting glucose and blood pressure. So those with shorter legs, indirectly suggesting they had faced an intrauterine adversity and therefore a body composition adjustment, were at higher risk of diabetes and hypertension. Sitting height had no prediction. What about 8-year glucose, HOMA-R, as a predictor of what happens at 21 years? We are looking at a life course evolution. This is a slightly complex figure, but I'll explain to you what it is. These are the betas on the regression analysis, which is suggesting a change in the outcome, which is all these parameters, in relation to glucose at 8 years. So a 1 standard deviation change in glucose at 8 years would put your carotid IMT up by about 0.15 SDs. It would put your fasting glucose up by about similar amount, fasting insulin and HOMA-IR, while it had no effect on these cardiovascular risk factors because they are crossing the either side of 0. So glucose at 8 years is predicting your carotid intima media thickness and all the parameters related to glucose and insulin. If you look at HOMA at 8 years, in addition to the glucose insulin, it then also predicts a lower HDL concentration, higher triglycerides, higher blood pressure. In other words, those who are insulin resistant at 8 years have a risk of being higher cardiovascular risk for all these parameters. And finally, I am showing here those who were insulin sensitive both at 8 and 21 years, and those who are insulin resistant both at 8 and 21 years, the difference was quite massive. Those who were insulin sensitive throughout, their average glucose 2 hour was 90. For those who were both resistant, 108, quite substantial increase. And if we look at hypoglycemic, 7% as opposed to 48%. Half of those who were insulin resistant both at 8 and 21 had higher risk of being either pre-diabetic or diabetic. Summary up to now, childhood HOMA-IR and adult cardiovascular risk factors are related. Those who are persistently insulin resistant had higher risk. Insulin resistance may be on the pathway between fetal growth and adult cardiovascular risk, and need for interventions in early life to improve the cardiovascular risk. In fact, I sit on a WHO advisory committee now because WHO is going to start a worldwide program called ECHO, Ending Childhood Obesity. And Margaret Chan actually wants that to be her gift to the world. So it's going to be a massive program which has now taken into account intrauterine factors to reduce the childhood obesity. This is the philosophy which the Danish philosopher taught us. He said life can only be understood backwards. So once we knew that birth weight was a problem, we wanted to decide how is birth weight determined. And that's how we started Pune maternal nutrition study in 1993. I've spoken about this in many meetings. As I said, because of embargo, I'm not going to show you the very interesting results we have in this study. But this is a unique study anywhere in the world which started preconceptionally, measured lot of things in pregnancy, lot of things at birth, followed children every 6 months, measured them extensively at 6, 12 and 18 years, and we have more than 95% follow-up. One of the unique high follow-ups in the world. In fact, actually I probably put an old slide. This is now over. We have completed 670 and again we are 95% follow-up for 18-year follow-up. I'm not going to discuss these results, but there is a very interesting life course evolution of pre-diabetes and central adiposity measured by MRI in this study, which I'll discuss in ADA. So all this suggests to us that though there is a genetic susceptibility, it is modified substantially by intrauterine programming, which we now believe is epigenetic. And there are complex mechanisms of either DNA methylation, histone acetylation, miRNAs, etc., which we are all studying now. And that changes how the genes are going to function later on. On top of that, subsequently, environment keeps acting on the epigenome and causes modification, so that the phenotype keeps continuously evolving. And people do a snapshot here, or as doctors, we look at patients in the clinic and look at the disorder. Therefore, we need a life course study like what we have done to understand how we come to this stage through these various intermediate phenotypes and what are the factors determining that and which is the most cost-effective way of preventing the disorder. And this is a new cartoon which I have put out in publications now to invite criticism and start thinking about prevention of diabetes, and the president of IDF has walked in. So I think we are going to actually push him to look at this model to actually try and convert it into translational phase during his stay in the IDF. So in summary, early life environment is important for lifelong health and disease susceptibility. Life course evolution of phenotype is one of the most exciting things which we have contributed from Pune for diabetes and for other disorders. This has implications for prevention. The first trial happened in Mumbai based on Pune results. The second preconceptional trial has started in Pune in 2011. We are now looking at detailed biochemical and molecular mechanisms, and I expect in future this will have an influence on public health and policy. We are helped in this by a large number of groups. Of course, all my staff in the department have contributed to measurements, thinking, and defining the protocols. We have collaboration with the MRC LEU, that's David Barker's unit, and Caroline Fall, who is the major Indian collaborator. I trained with these people, either in Oxford, and Helga Repsam from Norway, who taught us about one-carbon metabolism. And Andrew Hattersley, who is my old friend, and I interact with him on all genetics. And Graham Hittman and his colleagues. And Vardhaman Raikan, who is a very renowned epigenetic expert. In India, now we have set up a network, and this is funded by the DBT. We are now recognized as a Center of Excellence in Biotechnology. And we have now ICER in Pune, NIBMG in Kolkata, National Institute of Immunology in Delhi, NCCS in Pune, Indian Institute of Science in Bangalore, and computer agencies who are contributing to a massive omics study in our intervention trial. So in 5 years' time, we will have massive data on the genome, epigenome, transcriptome, metabolome, and microbiome on these studies. I think that's it. Thank you very much.